Everyone. It's a pleasure to stand here, and I'd like to thank RADCON and for inviting me as a speaker. I have my HOD in front of me, my co-workers, my seniors, my mentors, my seniors here, and we have international faculties and juniors and other colleagues. So it's a big honor for me to talk about very peculiar subject that is a lymphatic intervention, and it's a post-lunch session, so I know you are all lazy and okay. So yeah, it's a little bit atypical topic, and it's only me who is going to take this topic. So it's a lymphatic intervention, so it's not readily practiced everywhere. So yeah, I'll start. So I'd like to start with my own case. Okay, so what in this case, the pointer is showing that we were injecting lipiodol along the lymphatic vessels starting from inguinal lymph nodes, and we can see it's going to the cisterna chyli in the middle here. Yeah, we can see it here, and after that it's going up here along the thoracic duct up till the cervical region where the leak is there. Okay, so it was a 50-year-old female who had undergone total thyroidectomy for papillary thyroid carcinoma with extensive neck node dissection. After that, she had chylous drain of approximately 800 ml per day. So the surgeon tried to do surgical closure of the thoracic duct also, but even after that, the patient still had chylous drain coming out. So finally, we had to do this procedure. It took me 6 hours to do this. So I did it, and so we can see we also have cone beam CT. So we can see the lipiodol stain at the neck, at the area of leak. And this is it's good that only with lipiodol lymphangiography the leak was closed. Post-embolization, day 1 to 4, there was still 400 to 600 ml per day, and it was slowly reduced to 200, then 50, then nil in day 7. So that was a great success for me. So imagine how it works, okay? So the benefit is because lipiodol is a liquid embolic agent, and it causes inflammatory reaction at the site of leakage after aqueous hydrolysis and saponification of the surrounding fatty tissue, and leading to closure of that leak. So the therapeutic success rate is around 51%, and if the leak volume is less than 500, then it is successful up to 70%, and if the volume is more than 500 ml, then it is up to 35%, just with this much, only doing lymphangiography with lipiodol. It can cure that leak. So, okay. So as a diagnostic radiologist and intervention radiologist, we play a significant role in the development of lymphatic imaging and techniques and modalities. So we should be familiar with the anatomy and physiology of lymphatic system. There were some milestones in lymphatic imaging, like Kinmoth in 1952, he did the first pedal lymphangiography, which started all this. Then it was percutaneous thoracic duct cannulation by Cope in 1995, again by pedal lymphangiography. But it was the game changer came in recently. It is just 2011 that ultrasound guided intranodal lymphangiography was started by Rajabi et al. They published it, and then only all the imaging and the interventions boomed. So we are not that far. So it started late, so it's good for us that we are already doing it now. So, and then came the dynamic contrast enhanced MR lymphangiography, which is also a novel imaging modality. So we have to talk about anatomy. So we know lymph. So lymph is an extravasated interstitial fluid with substance and immune cells. Okay, that's what is lymph. So what does our lymphatic system do? So we know basic anatomy of our lymphatic system. Okay, so it plays a significant role. Why? Because it drains 8 to 12 liters of interstitial fluid daily. Okay, into the systemic circulation. That's a huge amount. Okay, so that's why. So when the limbs forms in the soft tissue or intestines or liver, or it's coming from the lower limbs, okay, so it gathers around by the lymphatic channels into the cisterna chyli. This is the largest lymphatic structure in the human body, and guess its size. It measures just 6.5 or 6.7 mm in diameter, and the length is 1 to 2 centimeter, and that's the largest we have. Okay, from there the lymph goes to the thoracic duct. That is the major central collecting lymphatics. It runs along the chest behind the heart, and it courses up to the C7 level, where it turns back and it drains at the junction of subclavian vein and interjugular vein. Okay, so that's the basic we know, but there is something known as right lymphatic duct as well, which also drains a lot. So that is from the right side of the head and neck, upper limbs, right thoracic cage, as well as both the lungs. Okay, so we should also know that there is something known as right lymphatic system. And it drains separately into the central venous system between the right internal jugular vein and subclavian vein. Okay, so that's the anatomy. And imagine this is a lymph node. As radiologists, I think we'll never see this in our ultrasound. So we have 450 lymph nodes in the body, and they have numerous afferent channels going together. Okay, going to the subcapsular sinus, the follicles, the superficial cortex, the deep cortical unit, then coming towards the medullary sinus and then hilum, then connecting it to the efferent duct and draining into the systemic veins, okay, or going into the other collecting lymphatic channels. Okay, so in this process, the foreign antigens and pathogens are filtered and are exposed to the immunocytes within the lymph node, and which triggers the body immune response. Okay, so and then it also receives blood supply from the medullary vein in its hilum. So that's how intranodal lymphangiography looks like. So we can see there's a needle pricking the lymph node, and this is the track that we can see. So this was first described in 2011 again, because this was a game changer. After that, all the procedures started happening very fast. Okay, there is something known as liver lymphatics. So how to see them? We can directly puncture percutaneously into the liver lymphatics, which is near the portal vein, central portal vein. So it's called transhepatic lymphangiography. So liver, it is source of 50% of lymph into the thoracic duct. Okay, its production starts from the smallest, that is the hepatic lobule, the smallest functional unit. From there, it drains into the sinusoids, into the space of disc between the hepatocytes and sinusoids. So we can see there it has deep lymphatic system, which drains 80% of the liver lymph into the central ducts. Okay? And superficial from the capsule, it finds other collaterals and then joins the central ducts. So any problems with liver lymphatics, we see hepatic lymphuria, non-chylous ascites, because it does not have chyle, and we can do embolization by using glue or coils after puncturing the liver lymphatics. So this is also possible. Next comes the intestinal or mesenteric lymphatics. So it starts from the lymphatic capillary in the villi, that is lacteals. From there, it courses submucosally, and it drains into the mesenteric collecting lymphatics, interconnected with the mesenteric lymph nodes, and then draining into the cisterna chyli. Okay, and what happens there? It's the lipid absorption is helpful in intestinal tracts. So the ingested lipids are hydrolyzed into fatty acids and monoglycerides and absorbed by the enterocytes. Okay, so when the long-chain fatty acids are re-esterified in the enterocytes, they form triglycerides, which are packaged with the lipoproteins, cholesterol, and other lipids to form what is called chylomicrons. Okay? These chylomicrons gave the name chyle with a milky color, and that's how the name came chyle. Okay? So if the source is from the intestine or after that, then the color of the lymph would be milky color. Okay? So how to approach that? So we can directly puncture into the lymph nodes intraoperatively, or here shown in a porcine model. Okay? With this difficult anatomy, it still has a lot of variations. So we can have normal course, okay, that I described. It can be completely left side course, completely right side course, proximal duplication, distal duplication, plexiform look, and sometimes there can be absence of cisterna chyli. And at the area of drainage also, it can be in between the two internal jugular vein or in the junction of jugulo-subclavian angle or the subclavian vein or into the other veins. Okay, so that variations can be seen here. So this is a single termination, bifid termination. This is a reanastomosis, okay, and there is complete termination. Okay, so it can be of different types. Now coming to imaging, how to image them. So up till now, we were with our cross-sectional modalities like CT, ultrasound, or MRI. We only see smalls, as they are very small. So what we see is only lymphoceles, lymphatic malformations, and lymph nodes. That's all we see. Okay, but with the advanced MRI nowadays, with two big things, the heavy T2 weighted MR lymphangiography, we can visualize the cisterna chyli and the thoracic duct, as well as static or slow flowing lymph that appears bright. Okay, and then of course we can, with the contrast, we can do T1 and T1 contrast. We can visualize the central collecting systems. The advantage of heavy T2 weight over the contrast enhanced T1 is that it can show other collection of fluid or lymph outside the central collecting system. The only problem with MR lymphangiography or other lymphangiography is it cannot show which direction the lymph is flowing. So for that, you have to puncture the lymph node and you have to do conventional lymphangiography. And we know that before we do any MRI with contrast, we make the patient fast. Okay, but in this case, it's different. So if you make the patient fast, the flow in the lymph flow is reduced. So what we do, we can make the patient eat fatty meal 30 to 60 minutes before the procedure, and we can see the visualization is much better. So here we can see this is gadolinium T1 control image and the MIP image showing the central collecting ducts. But with the heavy T2 image, we can see there is a lymph in the thorax, we can see, right? Chylothorax. So this is a bilateral pleural fluid. And then here we can see there's leakage of a lot of leakage in case of pulmonary lymphatic perfusion syndrome. And this is case of Gorman-Stout disease with the skeletal malformations as well as fluid collection in bilateral hemithorax. So we can visualize this with MRI. So next is we have to puncture the lymph node to start the lymphangiography. So it's very important because the first step is most important. So we know we can easily identify the lymph nodes, right? The superficial lymph nodes. We have to make a shallow track to keep the needle tight, okay, stable with 21 to 25 gauge. Then it should be better in the corticomedullary junction. At first, there will be pooling of contrast in the medulla, then slowly the beaded appearance will start. Okay? But the injection should be 1 ml per 5 minutes. So that's very slow. Okay? So go slow. And maximum you can inject lipiodol is 20 ml only. There used to be traditional modalities like nuclear symphantography, but we can see this is low resolution. And also this, you have to inject the radiotracer in the pedal areas, then slowly it will go up. So this is the pedal lymphangiography again, which was described by Kinmoth in 1952. So now how to approach cases. So if there's a case of, we have to know the cause, okay? So thoracic duct injury can be either traumatic or non-traumatic. Traumatic, either of post-operative, that is usually the thoracic surgery, cardiac surgery, or esophagectomies, or it can be penetrating trauma like gunshot injuries. Non-traumatic, it can be idiopathic, malignant like lymphoma, autoimmune diseases, lymphatic malformations, or other lymphangiomyomatosis diseases. Okay? So what happens, there is chylothorax, loss of fluid in ascites and cutaneous fistulas. There's a lot of proteins, loss of proteins, vitamins, and immunoglobulins leading to cachexia, immune system compromise, and sepsis. So it can be low output or high output. If it's low output, you can drain conservatively with chest tube, TPN, and octreotide, high output with surgery. So conservative management can be success rate up to 16 to 75%. So this was described by Sebum Her. This is the slide I took from his presentation when I was training, and this classically shows how to approach a post-operative ascites and divide accordingly. And this was from Japanese professor to his own paper for high output chylothorax. Okay, so how to approach is you can do trans-abdominal puncture of the thoracic duct after doing a lymphangiography. Directly, you have to puncture from the anterior abdominal wall straight to the cisterna chyli, and with using a 21 to 22 gauge Chiba needle. So that's very daring. Going straight, whatever it comes in front, you have to puncture it. May it be an artery or anything, but still there is no complications. So that was a big head-blowing thing. After the puncture, you can put a wire, put a catheter, then we know our job, okay? Embolize with embolic materials, glue on coils, etc. So we can see there's a direct puncture, and after that we can close the leak, okay? Or we can go, after visualizing, we can go translumbar and then puncture also, okay? That looks more safer. Then, or we can directly puncture into the leakage point and then do the embolization with other embolic materials. Or you can go retrograde, especially if it's a chylothorax case which is not getting treated. So you can go transvenous, put the catheter near the junction and try to pass through the junction, okay? So, but it's quite difficult because of a lot of septations or the valves, okay? So the complication is, the only complication we are scared is non-target embolization into the pulmonary vasculatures. So do not use Lipiodol more than 20 ml. Others are just some discomfort which is easily managed. So if you have right to left shunt or severe respiratory distress, do not do this. But if you do surgical thoracic duct ligation, there is high mortality, mortality, and failure rates. For delayed complications, what happens? There can be chronic diarrhea, protein lodging enteropathy, swelling, lymphedema, but these are all treatable. So now what? You did embolization, you closed everything. Now what will happen to that limb? Okay, so what happens due to the back pressure? There is opening of pre-existing lymphovenous communications at the lumbar levels, lumbar veins, intercostal veins, and azygos veins. So still the lymph will flow, it will find its way. So we don't have to worry on that. So thank you for listening. So this is my team where I work. There are cardiologists as well here, and these are my mentors, so I'm very happy to have them here, listen to me, and thank you so much.